I am also honored to introduce that the great professor from Italy, so Bruno Siciliano, is a professor of robotics and control at the University of Naples Federico II. And also, he is the grand first IEEE last president. So Bruno Siciliano, we'd like to welcome.
Okay. Yes, very good morning to everybody. And, I can add the words that this is fantastic, this format. Most of the presentations have been sort of retrospective. As a senior student and scholar in robotics, I always dream about the future. So I dare to speak not about what we have achieved. Indeed, some of our work has been covered by other presentations, but I want to share the enthusiasm that I have about a new project on a revolutionary Theranostics approach for robotized colonoscopy. So here is the challenge that we are tackling. It's colorectal cancer. Too many people die of CRC, of colorectal cancer in Europe, mainly because of lack of screening. The mortality rate of this cancer is about 50%. 600,000 cases were diagnosed in 2020 in Europe, and very sadly, 300,000 people died of colorectal cancer. So we want to fight this cancer, and we form a team. Robotics is about teamwork, as we know, with three colleagues, distinguished colleagues and friends: Alberto Arezzo from the University of Torino, one of the top endoscopic surgeons in Italy; Sébastien Urselin, an expert of AI and medical imaging from King's College London; Caspar Althofer, who was general chair of ICRA 2023 in London, who is an expert of mechatronics, soft and inflatable robotics, and my team on control and manipulation. So what are the research challenges that we are trying to tackle with this project? Is endoluminal navigation, it's in situ histopathology, it's supervised autonomy, and to integrate all this with the capability of achieving microrobotic surgery. And we were funded by the European Research Council in the 2023 call for the Synergy grants, and this is the Theranostics project, which will be engaging in the next 6 years. A few words about colorectal cancer. So this is typical colon, and those are the suspect pre-cancer mass, like they're technically called polyps. So a polyp has to be staged depending on the danger of mortality and spread to the other cells. So typically 5 stages are identified, and what you see below is the 5-year survival rate. So if the polyp is diagnosed timely, which means like in stage 0, stage 1, then a polypectomy is resolutive. On the other hand, if the polyp is too advanced, namely it's stage 2 to stage 4, then you have to resort to surgery, and most often the case with, you have to accompany surgery with chemotherapy and radiotherapy. Let's look at the 2 aspects. So one story is the diagnosis, and another story is the therapy. What about the diagnosis? This is a kind of rendering of the typical conventional colonoscopy. Why very few people undergo colonoscopy? Because it's a sort of uncomfortable, and to some extent it's perceived as a sort of undignified exam. Also, you need training skills by the operator. You want to be treated with a colonoscopy by an experienced endoscopy expert. Also, you have limited, Antonio was talking about hands, and you have limited maneuverability because you just have this kind of rubber tube which is inserted, and there is also somewhat the risk of perforation. I think, if I'm not mistaken, 3% of the cases, if there is a perforation, the patient has to be taken to the emergency room. And also, only small polyps are detected. What about the therapy? There is a technique which is known as the endoscopic resection, which actually it's very rustic because it has a sort of sneer, which is kind of hook. So the polyp is kind of circumstances, and then with poor vision, it tries to be excited, but at the risk of have some kind of high risk of perforation and unsafe oncological margins. So the problem with screening and mortality of CRC is that only 20% of the people undergo colonoscopy, and in case of an endoscopic resection, there is some unclear oncological margins in 50% of the cases. So a few words about the state of the art of research. I mean, there have been some contributions in the literature, either about the diagnosis or about the therapy of CRC precursor. It's like snake-like and continuum robots, reconfigurable and self-assembling robots, magnetically steered robotic capsules, and self-propelling robots. And I see many faces in the audience who have contributed to this advancement of this technology. So we felt altogether that there is a need of transformative research to enable a painless one-stop shop procedure for in situ polyp removal. So we put together these 4 research areas: endoluminal navigation, in situ histopathology, supervised autonomy, and microrobotic surgery, just to develop all together with our respective teams to bring together the complementary skills and try to improve the current technology in what we call a sort of theranostic, diagnosis and therapy at the same time. So this is a video which is kind of showing the rendering. It's the concept that we're going to develop in the next 6 years. So that's the patient on the operating room, and this is like the situation. So there are like 2 suspect polyps. There are residual phases after the preparation of the column the day before, after the purge, and this aversion robot is inserted in the column. It does first some kind of rinsing with the residual phases, and then it starts, just the real diagnosis of the polyps with a microcapsule, a microrobotic capsule, which has been developed by Alberto together with colleagues from Scuola Sant'Anna in Pisa. So this robotic capsule is inserted, and then it has to mark and possibly stage every suspect polyp. Then the question is, once you have staged a polyp, how do you operate? So the original idea is to inject a negative gradient of pressure in such a way as to suck the polyp and just absorb within the sort of operating theater, operating scenario. So when we do this, this is our capsule, which has like white light multispectral illumination, for imaging, of course, but it's also endowed with a multisensoral probe. This provides all optical ultrasound images, as well as a technique which is known as photoacoustic endomicroscopy, in such a way as to just stage the polyp and know what is the mass that has to be excised afterwards. Then it's the actual cancer removal with the micromanipulators. These are 2 soft, like micro arms, made by concentric tube technology. As I saw in one of the presentations yesterday, the concept of concentric tube in soft robotics, which seems very promising. And then one arm as a cutter and the other one as a fenestrated grasper in such a way as to excise with safe oncological margins. And once the polyp has been excised, then it's kind of aspired back, and then and it does, just along the column. So this is like in one image what is the concept that we're going to develop. I don't have to describe again, just you see what's the situation with the shuttle created by the aversion robot and the capsule itself. A few words about the scientific areas that we're going to tackle. Endoluminal navigation, clearly the state of the art, just has limited steering capability. Also, most of the designs are sort of heuristic, and also some of the trials, for instance, like by the group of Allison, Okamura, and also Elliot Hawkes at University of California, Santa Barbara, just like operation in no realistic environment. We have to operate this into the column. The innovation is the concept of fusion with structure in such a way that based on the best simulation, the best models that we have of the system, we can achieve deployment in situ of the instrument. And the breakthrough will be design of frictionless, shape-conforming robot, integrated sensor and microsurgical tool with embodied AI for navigation and control, real-time adaptation in constricted and dynamic environments. The second one is in situ histopathology. It's like, the thing is like, if the polyp is detected, typically there's a biopsy and the tissue has to be analyzed. We want to do the staging online because, that's the concept of the Theranostics. Also, in terms of the innovation, we will develop, thanks to the multi-sensor probe, like sensor analytics and machine learning techniques, and also we want to be able the system to cover an area as large as possible, and also everything has to be fabricated and miniaturized. So the breakthrough is the intelligent and multimodal sensing, including the 3 kinds of sensing modalities for in vitro, in situ detection, and characterization of tissue properties. Supervised autonomy, this was discussed widely also in the past 2 days. It's like, there was that provocative statement that intuitive surgical is just a teleoperated system. Of course, the new system has a sort of enhanced perception. So the idea is to use the concept of virtual fixture, which was used already for rigid environments. So the challenge is to develop this concept for soft tissues, and also to achieve some sort of shear control technique in such ways to achieve human-machine cooperation with perceptual feedback for model-based and data-driven control of both the navigation part along the lumen and also the actual surgery part for this kind of tight and constricted environment. Last but not least, we have to provide this technology with the surgeon. The surgeon will always decide, from the deontological viewpoint, this is the concept of a meaningful human control with the surgeon. And thanks to the innovation, we have a super flex, high-strength micro-robot with this kind of flexible jaws, and also for allowing the surgeon to achieve real-time intraoperative manipulation with this kind of bimanual system, which is based on this concept of continuum arm using concentric tubes for oncologically safe excision of polyps in the deforming colon. To summarize, that's the timeline with the implementation. We will advance the knowledge in the field during the first 4 years, and starting from the second year, we'll start like the innovation part, and the goal, the mission, is to achieve translation in the final 3 years. And we are foreseeing tests on human cadavers during the year 5, and also we filled out all the ethical protocol with the European Research Council for having tests on human volunteers during the last year of the project. These are the facilities available to the project, and integration will be carried out in the Medic Center at University of Torino. So this is the 4 of us. After the interview at Covent Garden in Brussels, we seem quite happy and confident that we would get the project. So I would like to thank them, and also for their contribution and their teams. And the final word of thanks is for my team. Just like we've been active in robotics since 35 years with the Prisma Lab. So it's a big word of thanks. And also it's like, I hope that the youngsters will continue this inspirational work just with my mantra, keep the gradient.
Thank you, Professor. Beautiful talk. Thank you, and great teams. So everyone, please do not worry about the coffee break, because this session started 9:10. So we have decided next session will begin at 11:10. So you have still coffee break time. Any questions, please? Raise hand and stand up, please. Anyone?
Yes.
Okay.
Thank you. Here.
Where?
Raja.
Okay, please. Yeah.
Very exciting. Thank you very much, Bruno. Very exciting project. Just small question. I didn't see anything about localization. Is there a need to localize the probe precisely in the body, or it's just because it's a probe?
No. It's part, just when I mention navigation, that's a very good question. When you mention navigation, also we have to be able to localize. And also we will exploit a model of the lumen, of the colon, of the bowel, and also, of course, you have a model of the probe. So it's like, so we can, it's a matter of also with the steering capability of locating the frame and characterize, because that's the main limitation, actually, of the current colonoscopy, which is done kind of heuristically, and there is no localization at all. But of course, when I meant the endoluminal navigation, this has to embed the localization, with just like with the actual frame and the ones available from the model of the system, and also the data of the patient, of course. Thanks for bringing up this issue.
Okay, thanks again.